It's my pleasure to introduce today's speaker, Dr. Ann Peters. Dr. Peters went to medical school at the University of Chicago and then did residency at Stanford and went on to do her fellowship in endocrinology at Cedars-Sinai. She stayed on there as faculty and then moved on to UCLA and currently works at USC. She is the director of the USC Clinical Diabetes Program and I think has a really interesting combination of serving the underserved and poor in East Los Angeles and also working with the haves and the wealthy Olympic athletes, et cetera, over in Beverly Hills. So she's got a very interesting, diverse practice. I've been fortunate enough to see her speak many times, and she's been invited to lecture at over 300 meetings. She has over 100 publications and is currently co-editor-in-chief of the ADA JDRF Sourcebook, on the treatment of type 1 diabetes, and is the co-chair of the ADA Working Group on the treatment of type 1 diabetes. She's also done a lot of amazing work in terms of research and has had extensive funding from the JDRF, Helmsley Foundation, as well as the NIH, and was the principal investigator on the Look Ahead trial, which many of you may be familiar with. This was the intensive lifestyle study that compared weight loss through healthy eating and increased physical activity versus a control group that she may touch on today. She's also been involved in the community-based cardiovascular risk reduction study and the type 2 diabetes medical home model study. Today, Dr. Peters is going to be talking to us about diabetes complications and her thoughts about how this has evolved and changed over the past decade, as well as give us her thoughts about medications, et cetera. So thank you, Dr. Peters.
Thank you. All right, so it's great to be here. And as you heard, I have a very psychotic life, but it's a good life. And every other day, I'm in the richest part of town and then the poorest part of town. And I think it keeps you very humble. But one of the things that's important to me is that I can provide diabetes care, good diabetes care to everybody. And as it turns out, as you all know, on the west side of town where my patients have health insurance, I spend about half my life doing prior authorizations because I want the newest and the best and the whateverest for those patients. And it's oddly easier on the east side of town where I actually get to shape a formulary. And so in my East LA patients, their biggest issue is access to care, but I've also managed to provide them the kind of care that I think helps. And as a result, I've also been able to work around the entire county. Our county is the most populous county in the United States, and it's larger in population than all but 5 states. So it's a very big area, and it's why, even though I'm from Madison, Wisconsin, and always dreamt about moving to a smaller town, I stay in LA because it's just got this huge urban population that I can impact. So the first thing, we're going to talk about complications, but I'm going to talk some about complications and then some about the new news in terms of complication prevention, because there's a lot that's exciting in the field of diabetes, and I want to share that with you. These are my potential conflicts of interest, and just so you know, I love to consult because I love to tell people what I think, and I consult for everybody, including the FDA. I'm a special agent to the FDA, which I thought might give me a special badge or something, but it doesn't. But at any rate, I love to bring my experiences because, frankly, a lot of people who work in just one part of town only have one perspective. And so I can bring my perspective from having access to everything to having a limited access in the East LA space and really work to try to help people understand what it's like to treat all people. So I like to help sort of champion the patients who may not have as much with all of these organizations. In terms of what we're going to talk about today, I'm going to talk about the pivotal trial data on the reduction of diabetes complications. Some of this will be a review, some may be new. I'm then going to talk about the new paradigm for treating type 2 diabetes, which isn't just glucose-based. And then I'm going to talk some about individual agents and their benefits. So about 2 years ago now, this article was published in the New England Journal of Medicine. And if you think about it, what we do for our patients is to introduce all sorts of treatments, right? So let's put aside lifestyle, because lifestyle really matters to me, but isn't really what I'm talking about. Do keep in mind, though, that at every visit for every patient, I always talk about lifestyle. And I try never to say the word diet because I'm trying to change people's habits for a lifetime. And I'm also trying to get them to exercise for a lifetime. And so I always talk about that with my patients. And I say you can always out-eat any treatment I give you if you put your mind to it, because diabetes is all about calories in, the right calories in, the right exercise. So in terms of lifestyle, that's a given. But in terms of what we're doing, I'm giving patients statins and ACE inhibitors and aspirin and diabetes drugs, and am I making a difference? Well, this study looks at 20 years, from 1990 to 2010, which really covers the time since I've been in practice, and asks the question, are we really making a difference in terms of a population base? Down at the bottom are the overall data, but up at the top are the population with diabetes. And this looks at 5 major events: acute myocardial infarction, stroke, amputation, end-stage renal disease, and death from hyperglycemic crisis. And as you can see, over the past 20 years, rates of all of these events have declined very significantly. So whatever it is we're doing, this cocktail of drugs that we're giving our patients with diabetes, we're making their outcomes better. They're living longer, they're living better. So this is great validation for what we do. This is outside of a clinical trial, this is real world. But there's 2 things to notice. First of all, interestingly, these people, the general population isn't seeing nearly as much of an improvement. But if you think about it, they don't have nearly as much to lose. Because if you look at the y-axis here, this is events per 10,000 adult patients. It goes up to 150 and comes down. This starts at 10. So if you look at the events in the general population, they're much, much less, even still, than on our patients with diabetes. So it means we have a very long way to go before these patients come down to where these patients start. So our work is still cut out for us. Now, the most classic diabetic complication is retinopathy, because diabetic retinopathy is really unique to diabetes. Nephropathy, neuropathy, other complications are all multifactorial and can be due to other causes. And if you think about it, we're actually reducing the rates of vision-threatening diabetic retinopathy in patients who have access to health care. So on my West Side clinic, in the old days, I used to have people come with seeing eye dogs. It used to be 20, 25 years ago that I'd always have one patient in clinic that day who was blind. Now I don't have any patients who are blind in my West Side clinic. And when they bring dogs, they're hypoglycemia alert dogs or just dogs in general. I love creatures, so I encourage people to bring their animals because it's friendly. But we also have many, many, many more people with diabetes, and we have many people who don't get access to health care around the country. So the actual number of cases, because the number of patients with diabetes is doubling. So in the past decade, we've doubled the number of patients who have significant diabetic retinopathy. And that's a problem. So as an individual, I know I can help prevent this. But in a population, it's very hard to do unless people all have access to good health care. And this is shown particularly here. This looks at diabetic retinopathy rates by age and race. And the green are the Hispanic patients. And you can see that rates of retinopathy go up with age, but particularly so in our Hispanic population. So again, lack of access to health care and potentially some predisposition genetically in the Hispanic population to get more retinopathy really increases their risk. Now, this is the classic photo that I'm sure you saw in medical school of what diabetic retinopathy looks like. And we're all very limited when we just look through an undilated pupil, but these days there's all sorts of screening cameras and ways to get images. But clearly this person's at terrible risk and may well be having some macular involvement, which could lead to true vision loss. So this is a patient where you need to have them see an ophthalmologist immediately. This person may not be having any changes in their vision. I have a lot of patients, even on the West Side, who say, oh, I don't need to see the ophthalmologist. My vision's fine. but that's not the answer. The answer is this could be happening in the back of your eye that may need treatment to prevent vision loss. So one of the things is that now we have all sorts of better ways to intervene. So in addition to preventing retinopathy, which we do through both glucose and blood pressure control, we now have a number of different interventions, from laser photocoagulation, which we've had for a long time, but it's becoming much more refined. Vitrectomy is an old treatment, but still effective in certain cases. Anti-VEGF therapy, which I think has made a big difference in terms of my patients preserving their vision. And then we have intravitreal steroid injections as well. So there's not just one thing we can do when patients develop significant retinopathy. And this is just what it looks like to get photocoagulation. The laser beam is very specific. And if you look in the back of someone's eye who's had this kind of panretinal photocoagulation, you can see all the little laser scars and the preserved central vision. So this works. And I have a lot of patients who have had type 1 for 50, 60 years, who maybe 20 years ago had photocoagulation for their retinopathy, who've been stable ever since. So it's amazing to me how much stability I see in people's eyes. They'll often go through a time when things aren't so stable, but then seems to me to settle down, and they do well over long periods of time. Anti-VEGF injections are obviously injected right into the eyeball. And one of the things I tell my patients is, this looks like the most scary thing on the planet, but it isn't. And it just requires a sense that this is something that can really help. The eye is numbed. This is a little bit uncomfortable, but it really doesn't hurt, and people are fine right afterward. But I think this has really changed outcomes in my patients, and many of my patients have these shots regularly. Unfortunately, we don't know if you can ever stop having these shots. So you get them at first in a cadence of once a month, then it's once every other month. And there's some approaches now where they're doing some laser and some injections to try to minimize how long people have to go on to get the anti-VEGF injections. And this is just a slide. This is somebody who has very obvious and very bad macular edema, who's much, much better post-treatment. So anti-VEGF therapy works. I think it's been something that's really been an important addition to the treatment of my patients, and it just requires a little bit of hand-holding to people who are afraid of it. I'd be afraid of it too, but I'm telling you, people don't really seem to mind. Once they've had it, they go back for it, and it works. Now, in terms of renal disease, it's much the same. So even though rates of nephropathy are going down, if you look at the numbers of patients with nephropathy due to diabetes, it's still the largest part of the pie. And that's because we have so many more patients with diabetes. We need to prevent diabetes, just a thought, but that's another lecture. I'm doing a study, an NIH-funded trial called, it's called D2D, but we're looking at vitamin D and the prevention of diabetes. It'd be nice if something that simple turned out to be helpful. So how do we deal with this? How do we prevent complications? Well, we have a lot of data now that guides us. The most important data comes from UKPDS and DCCT. So UKPDS was in patients with type 2 diabetes, followed in the UK, and they're new onset patients. And they're followed now for over 20 years. There was an intervention phase for 10 years, and then this long-term follow-up. DCCT was done in people with type 1 diabetes. They were younger, had shorter duration disease, and we follow them now for over 20 years. So we basically have these two cohorts of individuals where we have this long-term follow-up so we can see the benefits as to what we've done. And the cleanest data comes from DCCT because all these patients have coming in as diabetes. They don't have cardiovascular disease. They don't have other complications. Then we have studies here, which I'm going to explain later, in patients who have advanced diabetes. They've had type 2 diabetes for a long time and established complications. And I'm going to show you what happens when we give them tighter control as well. But DCCT was this wonderful study. It had 1,442 individuals with type 1 diabetes, and they were randomized to the intensive treatment arm or the control arm. The A1C in the control arm was around 9, and in the intensive treated arm around 7. And that's pretty much the best they could do. They wanted to get people below 7, but it was harder to do that in a larger group. And also, this is before we had a lot of the analog insulins and continuous glucose monitors we have now. So we didn't have all the tools, but we had a lot. And if you look at primary prevention in the DCCT, and this is now looking at retinopathy rates, if you come in without retinopathy and your A1C is 9% over 7 years, this is what happens. You have a very high risk of developing retinopathy compared to those who are intensively treated. And if you come in with retinopathy, rates of retinopathy or significant change in retinopathy goes up until it's sort of like that improved glucose kicks in, and now you start seeing this split between the two groups that becomes very significant. So whether you have initial no disease or you have some retinopathy, tighter control, that 2% reduction in A1C, the difference between the groups is very significant. Now, what happens in the DCCT patients? So after 7 years, the results are published, everybody's ecstatic. First time we've ever said for sure glucose is the cause of diabetic complications. Believe it or not, before that there was a lot of waffling, but now we know. So the intensively treated groups are no longer in the system of the study. And in the study, they have parties, they have study coordinators, they're cheering you on, they're trying to get your A1C to 7. It's somebody's full-time job to make sure your blood sugars are kept in a good range. Well, that kind of goes away. Now, these patients are still educated, they're still people who've been well controlled for 7 years, but they say, gee, it's been a little bit too hard. So their A1Cs drift up to 8, where they now stay for the rest of time. These intensively treated, conventionally treated patients, they've kind of just had it easy. They haven't cared that much, but they see the data and they say, oh, well, I've got to get better. So they bring their A1Cs down and they stabilize at 8. So now everybody, whether they were intensively treated or conventionally treated, now has an A1C of 8 for the next 20 years. This is basically, on average, what they do. So that's where we have these A1Cs. And yet, that 7 years of tight control early continues to have a benefit. So this is the first 4 years. Now everyone's A1C is 8, but there's still this big split between intensive therapy and conventional therapy. And this is a theme because this is what happens in type 2s as well. Tight control early means forever you're going to have a benefit, that really has set the stage for the fact that you didn't have damaging hyperglycemia early, so you end up having better outcomes. Then what happens is they keep following them. So we're now, this is data at 20 years. And early on, these patients don't have cardiovascular events, right? Because they're young, healthy type 1s. But now they're becoming 40-year-olds, 50-year-olds. And over time, look what happens to this MACE, which is the typical MACE of non-fatal MI, cardiovascular event, or death. Look at the conventional group. Their rates start going way up compared to the intensively treated group. And so there's a very significant risk reduction. And just to be clean, the patients are the same in terms of treatment with statins, blood pressure control, everything else. So this really is a long-term benefit, again, from tight control now, years before, in terms of reduction in cardiovascular disease. So what we see is that early treatment, and obviously if you kept that up over time, we believe you'd have continued benefit, reduces the risk of micro and macrovascular complications. So what this table does is it says UKPDS type 2s, DCCT type 1s, short-term and long-term, very significant microvascular risk reduction, short-term no cardiovascular risk reduction, but over time, a reduction in both studies, and in UKPDS over time, a benefit in terms of mortality. So basically, when you're treating someone's hyperglycemia, you're in it for the long haul. It takes years to see the maximal benefit in terms of cardiovascular risk reduction, although quickly we see a reduction in microvascular risk. And a lot of our patients say the microvascular risk is what affects their quality of life. So it's retinopathy, nephropathy, neuropathy. Basically, reducing sugar reduces those complications. and then longer term will reduce cardiovascular risk. Now, I told you I'd tell you about ACCORD Advance and VADT. So these studies got slightly greedy. And what they said was if blood sugars of 7 reduce your risk over time in terms of cardiovascular mortality, what if we get your A1C level down to less than 6? And so in ACCORD, they took patients with primarily known cardiovascular disease or at high risk for cardiovascular disease. So these are type 2s, they're older, they've had diabetes for 10 years, and many of them already have the disease, the macrovascular disease that we're worried about. And they start getting them under better control. And they give them all sorts of insulin, and they fight really hard to get their A1Cs below 6. Well, a lot of these patients, I personally wouldn't have even tried to get their A1C below 6, right? So this is some 74-year-old guy with heart disease. If I got his A1C down to 6.5, I'd be ecstatically happy. But they keep pushing him down. And pushing him down reduces, and these other trials weren't quite as intensive, but reduces microvascular complications. But in ACCORD, at 3 years, what happens is there's an increase in mortality in that intensively treated group. And this makes everybody, of course, quite perplexed. And they stop the study. Now, every one of you in the room will say that that happened because they had more hypoglycemia in the intensively treated group as they're trying to get their A1Cs down with insulin. Well, it turns out that's not the answer, but they did teach us something about hypoglycemia. So if you take the 3 trials, ACCORD, Advance, and VADT, and look at rates of severe hypoglycemia, meaning someone has to help you because you've passed out on the floor, it was interesting. So all these are studies with older people, right? And it was very hard to really adjudicate the severe hypos because, you know, some guy would be sitting in front of his television. He'd feel a little low, and he'd ask his wife to get him some juice. Now, that is assistance for treating hypoglycemia, but that's not what we're talking about. We're talking about severe hypoglycemia where you couldn't get the juice if you wanted to, not just because you're lazy and don't want to get out of your chair. So we had to really figure out in these trials what was severe and what wasn't. But when you look at the severe cases where people are incapacitated by hypoglycemia, what we find is that there's a very marked increase in annual mortality if you've had one episode of severe hypoglycemia. So the yellow are patients who've had severe hypoglycemia. This is annual mortality. And the blue are patients who have not. It turns out, though, that it didn't matter if you were in the intensive group and had a severe low or in the standard group and had a severe low. Severe hypoglycemia is very bad. It's a very bad portent for death in patients over time. And so your A1C could be 10 and you'd have a severe low, or it could be 6 and you'd have a severe low. It's the severe low that hurts you. So from the trials, we came out with this data. Patients with type 2 diabetes who experience symptomatic severe hypoglycemia are at increased risk of death regardless of the intensity of their glucose control. So we obviously want to avoid causing severe hypoglycemia. But the second thing is that the increased risk of death amongst participants in ACCORD in that intensive treatment group was not caused by severe hypoglycemia. And in fact, we'll never know because they've done now 12,000 different analyses. And they can't tell because in the intensively treated group, they were treated so differently. They were given these insulin algorithms, they were adjusted, all of this stuff was going on, and they can't really figure out why the patients had this excess in mortality. But it does tell us that there are patients, and we have to use our clinical judgment here, that really shouldn't be intensively treated. And in fact, if you have patients where you try and try and try and their A1C stays elevated, it may be that that's just the best you can do and that it may not be in their best interest to keep trying to force it down. So following the ACCORD trial and other research, the ADA, and I worked with them on this to try to figure out what the best targets were. So it used to be that kids had different targets depending on their age group. So we took that away, and we said if you're less than 18 years of age, your target's less than 7.5. If you're an adult, your target's less than 7. And frankly, if you're young, healthy, and otherwise motivated, I'd love to have your A1C even closer to 6. But I look even within my adult population and stratify this. And then we took what used to be for the youth in terms of targets and flipped it to the older patients. Because it turns out severe hypoglycemia is more common as you get older and more deadly. So we said, if you're older, and we don't define older, because we let you define older, and we let you define healthy and how sick they are, we have different targets. And so what I do is I literally, on each patient, I write down the target. And sometimes my target and the patient's targets are different. But regardless, I write it down because if anybody wants to tell me that the fact that I have A1Cs in my patients that are still 9, then I say, well, that's the appropriate target for the patient. There are some patients, I have some really brittle elderly patients who are post-pancreatectomy who are so sensitive to insulin that I just consider any A1C a target because I don't want to hurt them because they're so sensitive to insulin. But I make it clear what my target is. And I just think that one of the things about all of the performance measures that we're increasingly subjected to is that you have to look at the patient, the complexity of the patient, what's better for them. And ACCORD really showed us that you can't apply those very tight targets to an entire population of high-risk individuals. So ACCORD really made us think that we could do harm. And it was, you know, it's why you do these studies. It was disappointing, but nonetheless helpful. Now, what do our patients with diabetes die from? Cardiovascular disease. And it turns out that we know how to lower LDL. So if you look at the studies that look at LDL lowering in people with diabetes, what you find is that there's a linear relationship between how low the LDL goes and the clinical event rate. And that's great. But every single time I have a patient who dies of a cardiovascular event, and I actually don't have that happen commonly, I race to the chart to see how did I do. Was this someone where I failed to give them a statin? Was this someone whose blood pressure is too high? What did I do that led them to have a cardiovascular event or death? And so we're actually really good at lowering LDL, and about this much risk is attributable to LDL. But patients with diabetes still have this huge residual risk. And that's why their rates of cardiovascular disease are so high. We can do all the obvious, but they're still getting cardiovascular disease and dying from it. So this is something that there's been a lot of research looking at, and a lot of it's failed. So giving a pharmacologic agent to raise your HDL didn't work out. There's other things we've tried that didn't work out. But interestingly, there are some things now that we can do to reduce this risk. Now, this is the algorithm that we came up with a couple of years ago. And I know it's very hard to follow, and it's very colorful. And the ADA just folded this into something that doesn't have boxes. But the point of it is as follows. I can't tell you how to treat a patient with type 2 diabetes because your patient is different and your setting of practice is different. I can tell you that metformin is the single best drug for people with type 2 diabetes, bar none, and prediabetes, and maybe just getting older. Metformin is genius. So this should always be in your mix if you can get a patient to stay on it and their renal function's okay. And renal function okay means an eGFR of greater than 30 now. They cut away all the creatinine cut points. But after metformin and lifestyle, you then can choose whatever it is that suits your patient. Now, I personally don't use sulfonylurea agents if I don't have to because I don't like hypoglycemia and weight gain. But in my county patients, I have to use a sulfonylurea agent next. That's my next step. And so I can do that. I can do almost anything to try to get patients healthier. But we also have agents like DPP-4 inhibitors and SGLT2 inhibitors and GLP-1 receptor agonists. These drugs don't cause hypoglycemia or weight gain, and they may be my preference in the appropriate setting. And then we go down to mixing and matching, and I'm not going to go into that. But I am going to tell you that even though this algorithm is made based on glucose, it turns out that we now know that medications for diabetes have non-glucose-related benefits. So metformin, TZDs, SGLT2 inhibitors, and GLP-1 receptor agonists all reduce the risk for certain kinds of cardiovascular disease. That's pretty cool. And so just thinking about it, if you can put a patient on a medicine that lowers their sugar and their cardiovascular disease risk, that's pretty much win-win. And then there's pioglitazone, which turns out to have a direct and specific effect on fatty liver disease. And both SGLT2 inhibitors and GLP-1 receptor agonists also affect renal function for the better. So they have a positive benefit independent of glycemic lowering on renal function. And then finally, SGLT2 inhibitors reduce the rate of congestive heart failure. So now we have diabetes drugs where we can start looking at them differently, not just for glucose, but for these other positive benefits. And I'm going to talk specifically about these benefits. So first of all, metformin. Now, I am a doctor who hates pills, right? I never wanted to give people medication, and I used to never treat prediabetes with metformin because it was a medicine. But then all this data has been coming out about metformin. The NIH has a big trial now looking at metformin in healthy aging, in people without diabetes or prediabetes, because it does all these wonderful things. And it's been out since 1957. We know all about it except how it works, but that's irrelevant. But we do know the side effects. And it turns out that if you look at patients with diabetes, they're going to have a lower life expectancy than without, right? But if you look at people with diabetes who are treated with metformin, not only do they live longer than people with diabetes not treated with metformin, they live longer and are healthier than people without diabetes at all. And these are the kind of epidemiologic studies that have made us think maybe there's something about metformin that helps with the aging process itself. And this was a study that was just published 2 days ago that looks at age-related comorbidities, which are in this study ARCs, and then they look at all these diagnoses that are part of that: cardiovascular disease, cancer, depression, dementia, frailty-related diseases in men with type 2 diabetes. This is a big study, and again, this is all epidemiologic data. But this is 41,000 men, and in the year 2000, none of them had any of these age-related comorbidities, and 10 years later, they're looking to see how many have them. And what they found was that being on metformin, and these are all people with diabetes, type 2 diabetes, reduced the risk of all the age-related comorbidities. But whether you had strong benefit depended on your risk. So if you were in the high risk for cardiovascular disease, your risk of cardiovascular disease reduced by 48.6%. And in those individuals they decided were in this high cancer risk, their risk of cancer, this should be cancer, was reduced by 45%. So we think that metformin is in some way interacting at the level of the mitochondria. It's doing something that's helping reduce risks of a lot of problems that just aren't diabetes related. So I put everybody I love who's over the age of 50 on metformin, just a thought, because I want to prevent them from getting all of these other problems that can coexist. So metformin is actually one of those stealth agents that may really have a role in a larger population than just those with prediabetes or diabetes. The data's not in yet, but it's going to take us a long time to know the answers. The one thing you have to do when you give people metformin is to give them vitamin B12, because metformin slows, it makes you malabsorb a bit, and you malabsorb B12. So in the studies where they look at dementia rates on metformin, if there's not adequate vitamin B12 levels, dementia rates are not reduced. So people should take vitamin B12 along with metformin. Now I'm moving on to SGLT2 inhibitors. And in case you all don't know what these are basically drugs that make you glycosuric. They make you pee out glucose. And they work by inhibiting SGLT2 in your proximal renal tubule. And what this does is that SGLT2 pulls glucose back into your circulation from your urine. And it's enhanced in people with type 2 diabetes. If you block this, then you pee out more glucose in your urine. It's a diuretic because you pee out more fluid and glucose, and you pee out calories. So people lose weight, their blood pressure gets better, and their blood sugars improve on an SGLT2 inhibitor. And just to show you what happens to your renal threshold, this, say, is somebody who doesn't have diabetes. If you have diabetes, your renal threshold shifted to the right. But if you give someone an SGLT2 inhibitor, it shifts it to the left. So now, and my patients notice this, if they go out and eat pasta for dinner, they're going to have much more nocturia than if they don't, because their carb levels, their glucose levels are higher. They're more glycosyric, because this is making them glycosyric at a lower blood glucose level. And so when I first heard about these drugs, I thought this was stupid, right? Because when I started training, we were still dipping urines for sugar, and I thought this is really dumb, because everybody on these, if you send them to a urologist and they check their urine, they're all glycosyric as heck. But it turns out that this is a really good thing for your body. And we don't know all the reasons why this is so good, and I could go into theory, but I'll just suffice it to say, is it seems to be good for you to lose a bit more glucose in your urine, possibly because it makes you slightly ketotic. So we know these agents now exist. There's canagliflozin, Invokana, dapagliflozin, which is Farxiga, and empagliflozin, or Jardiance, which I'm going to talk most about. Now, this mechanism of blood sugar lowering is independent of beta cell function, and the major side effect is an increased risk for mycotic genital infections, more so in women than in men, but in both, and you need to warn patients about that. There are issues related to volume depletion, so in some elderly people, they really can't tolerate this much volume loss because, again, it's like a diuretic, and so you may have to reduce a diuretic if they're on it, watch them closely, and there are cases early on where they develop acute renal failure, so volume depletion is important to be aware of. And there's a renal cut point of less than an eGFR of 45 for empagliflozin. The others have a higher renal cut point, but you've got to make sure a patient has a reasonable eGFR for these agents to be effective. So this is the real headline about these agents. So you know, because of issues a number of years ago, the FDA requires all the companies to do cardiovascular outcomes trials. And these are great big studies, and they're all done the same way. Patients under their normal, regular care with doctors all over the world, they're in the study, and they're randomized to whatever the drug is and placebo, and then they're followed, and we look at cardiovascular outcomes. And all this is supposed to do is prove safety. It's supposed to prove that these drugs work to lower sugars, do it without causing an increase in cardiovascular events. And so in this study, the EMPA-REGS trial, they took 7,000 patients and randomized them to placebo and 2 different doses of empagliflozin. And these were really typical type 2 patients, but every single patient in this study had established cardiovascular disease. That's very important. These are not at-risk patients. These are patients who were diagnosed with cardiovascular disease. And the only key exclusion criteria was an eGFR of less than 30. So they put the patients on the empagliflozin, and a couple things happen. Their blood sugars get better, but not a ton better, right? This is only a 0.5% reduction in A1C. They start out at about 8, so they're not that high. And then they drift up a bit over the course of the time in the trial. But what we found in this study was that it didn't matter which dose of empagliflozin you were on, 10 or 25. The results across the board were the same. So 10 milligrams is the same as 25 milligrams. And it turns out when I was trying to convince the County of Los Angeles to put this on the formulary, half of a 25 is the same pretty much in terms of effectiveness and half as much. So just a thought is if you're trying to save your patients dollars, you could actually cut the pills and you'll get the same effect. A1C was there, but more importantly, potentially, was this impact on blood pressure. So you see, again, same effect both doses, and a reduction in systolic blood pressure that's sustained over the course of the trial, and a reduction in weight. This was the first trial with a diabetes drug where there was a very significant reduction in MACE, and this was a 3-point outcome that looked at cardiovascular death, non-fatal stroke, and non-fatal MI. And empagliflozin was much better than was placebo, and the difference between the 2 groups starts out at the very beginning of treatment. This isn't some remodeling of plaque. This is something that happens right away. And if you look at cardiovascular death, 38% difference between the empagliflozin-treated patients and the placebo-treated patients. It almost starts the first day you go on the study drug. Look at the incredible immediacy to this effect. And the same thing for hospitalization for heart failure, almost immediate. So this clearly is having a hemodynamic effect in terms of what's going on, in terms of reduction of risk. On the other hand, we don't really understand it because if you give somebody a diuretic, say in the old-fashioned diuretic trials, they didn't see this kind of benefit so quickly. So this drug is doing something that we actually don't understand that's both hemodynamic and potentially in terms of shifting substrate to improving patients and reducing cardiovascular events and reducing hospitalizations for heart failure. And if you look at this compared to other trials, this was the old 4S trial with simvastatin. So in that trial, you had to treat 30 patients to prevent 1 death. In the HOPE trial with ramipril, you had to treat 56 patients to prevent 1 death. And these were over 5 years. In the EMPA-REG trial, you had to treat 39 patients to prevent 1 death. But what's wonderful to me is this is dealing with that residual risk. Because all of these patients are on statins, ACE inhibitors, ARBs, aspirin with good blood pressures and reasonable blood sugars. These are those patients we've already risk reduced, and we're adding this in and reducing their risk of cardiovascular death by 38%. So this is in addition to everything else we do. And that's why I found this trial so impactful, because now we can do both cardiovascular risk reduction as well as reducing glucose levels. The FDA noticed this, and now the first ever diabetes drug with a cardiovascular indication in the label. So Jardiance is now indicated for treatment of glycemia and to reduce the risk of cardiovascular death in adult patients with type 2 diabetes and established cardiovascular disease. We don't have data with any of the other SGLT2 inhibitors, and we don't have data in patients who are at high risk but don't have cardiovascular disease, but we do have the data from the EMPA-REG trial. Now, it turns out that it also helped preserve renal function. And everybody was worried about SGLT2 inhibitors in the kidneys. But here's the empagliflozin group. This is the cumulative probability of incident or worsening nephropathy. And it was significantly less with the empagliflozin-treated group. And if you look at renal function over time, you do see an initial worsening of eGFR as patients are getting used to the new volume status with their new empagliflozin diuretic-like drug. But you see that renal function basically stabilizes and the placebo group goes down. So this has a positive renal benefit as well, and canagliflozin has also been shown to have this benefit. So a renal benefit and a cardiovascular benefit from this drug. Now there was a concern about stroke because stroke didn't reduce in this study, and that's a whole other issue, and there's going to be a paper published in JAMA Neurology this month looking at that. But it turns out that there was an increase in stroke rates in the 2-month off trial. So patients stopped the empagliflozin and their risk of stroke went up, but that wasn't related to changes in blood pressure. So again, all of these studies have puzzles that make us ponder what happened, but it wasn't on the trial, it was off the trial where patients had this problem. So if you put someone on empagliflozin, keep them on it. Now, TZDs, we've had pioglitazone and rosiglitazone. We know what's good and bad about them. They target insulin resistance. They can cause fluid retention and congestive heart failure and bone fractures and everything else, but they're still the only drug that we have that preserves beta cell function. And as it turns out, they're really good in patients who've had a stroke. So they did this study, which is pioglitazone in patients with pre-diabetes and insulin resistance who've had a stroke or a TIA. They randomized them to pioglitazone or placebo, and they showed a significant benefit to pioglitazone. So here, this is cumulative event-free survival. They did better than the patients who were on placebo. And remember, once you've had a stroke, you're at very high risk for having another cardiovascular event. And again, to put this in context, these are the other treatments we have for secondary stroke prevention: statins, aspirin, ACE inhibitor. Pioglitazone is right up there in terms of its benefit, in terms of reducing the risk for recurrent cardiovascular event after a stroke. So a little pioglitazone in the mix might actually be beneficial in terms of patients who've had a stroke. Next, there's this really good trial where they do liver biopsies in patients with non-alcoholic steatohepatitis, and they compare pioglitazone to placebo. This shows you the plasma ALT levels, because I don't routinely do liver biopsies. I do look at ALT levels. Pioglitazone lowers ALT levels, and they stay down. Placebo ALT levels come down a bit, but they stay high, and then come down when they're added pioglitazone. And if you look at the liver biopsy data, this looks at liver biopsy-proven resolution of NASH. You had 21% resolution in placebo and 58% resolution with pioglitazone. So pioglitazone seems to have an independent effect on fatty liver. We've thought this for a while, but this was a really clear study that showed the benefit. Now, GLP-1 receptor agonist therapy. We all know about DPP-4 inhibitors, which are sitagliptin, saxagliptin, linagliptin, and allogliptin, and they inhibit DPP-4, which breaks down GLP-1, so you get somewhat higher levels of native GLP-1. DPP-4 inhibitors are pills. They're easy to take. They have A1C reduction. They're weight neutral and don't cause hypoglycemia, but in all of their cardiovascular outcomes studies, there's no added benefit. So they're safe, and saxagliptin might increase the risk of congestive heart failure, but in general, DPP-4 inhibitors are glucose-lowering drugs that are easy to take and easily tolerated without hypoglycemia, but they don't have some of these added benefits. GLP-1 receptor agonists, on the other hand, are injectables. They give you more glucose lowering, and we have exenatide, liraglutide, albiglutide, dulaglutide, and lixazentide now on the market. And these drugs are, again, injectable, and they come with some GI side effects, but they do help with weight loss and without causing hypoglycemia, and as I'm going to show you, cardiovascular benefits. So this is the LEADER study. This is liraglutide, and this is their cardiovascular outcomes trial. Again, simple study, the active drug, liraglutide, versus placebo, and they're followed for at least 3.5 years or until they get to 611 events. And these are now patients, 80% of whom have established cardiovascular disease, and 20% of whom are at risk for cardiovascular disease. So it's not all patients who've had the disease. And basically, you see a very similar effect. There's a reduction in A1C, and these patients started an A1C that's higher, about 8.8. It comes down, stays relatively low, but does come back up over time, and there's no effect on blood pressure, and there's no effect, there's some effect on weight. And again, you now see, for the second time, an improvement in their primary MACE. So there was cardiovascular death, non-fatal MI or non-fatal stroke, and again, a significant reduction, positive for superiority, comparing liraglutide to placebo. But this effect is different than the empagliflozin effect because it doesn't start until about 12 months. This is more typical for what we're used to with a drug like a statin, where you start to see an effect between 6 and 12 months. So what liraglutide is doing is different than what empagliflozin is doing, and it's working somehow on a different pathway. And again, we don't know exactly why, but this research is ongoing. This looks at cardiovascular death, and again, a robust reduction in cardiovascular death, and again, it starts at about a year. So you could ask the question, what if we combine these two drugs? What kind of benefit would we see there? And we don't know, but clearly this is a different mechanism through which this agent is reducing the risk of cardiovascular events. And just like with EmpaReg, there was a significant reduction in nephropathy. This is time to first renal event. And these are significant renal events, doubling of serum creatinine, development of macroalbuminuria, end-stage renal disease, or renal death. So liraglutide was also beneficial in terms of renal function. So both of these drugs now, positive benefit on cardiovascular outcomes, positive renal benefit, and glucose lowering will affect diabetic retinopathy. So the reason I find diabetes so exciting now is that I've been spending my whole career talking about glucose lowering and microvascular risk, but now I can talk about reducing both micro and macrovascular risk. We have drugs that can do this, starting with metformin, and I think we can use good combinations of these drugs to help patients reach and maintain their targets. Human beings are still human beings, however, and there's still a lot of issues that we have to deal with, the willingness of people to change, to accept our advice, to get them to target. And I always stress lifestyle modifications, as I mentioned. There's a lot more research we need to do because every trial just asks more questions than it answers. But I think it's a really good time to be treating our patients with diabetes because I think we can do better than we've ever done before. Thank you. So do you guys have questions? Yes?
curiosity question and then a more serious question. So the curiosity question is on your very first slide where you listed the companies you worked for was Bigfoot Pharmaceuticals. And that, what the heck is Bigfoot Pharmaceuticals? And then secondly, related to that, you did mention peripheral neuropathy.
No, I didn't. The question was, what is Bigfoot Pharmaceuticals and what about peripheral neuropathy? So peripheral neuropathy, I'll answer this backward. Peripheral neuropathy is, if you ask me, one of the singularly most disabling and untreatable complications of diabetes. And it doesn't have an independent treatment other than prevention. And so, yes, I could have put it on there. I should have put it on there. But because I don't have anything special to add, and none of these studies can easily look at peripheral neuropathy, because it's a feeling in most cases. It's not something I can measure. I can measure your creatinine. I can measure, look at your eyes, but peripheral neuropathy is very hard to study. And so in these trials, they don't give you good markers of peripheral neuropathy. So we don't have a lot of data, except we believe from suggestive evidence that lowering sugars will reduce peripheral neuropathy rates. But that's the complication I just fret about the most, because once you come to me with peripheral neuropathy, there's not a heck of a lot I can do to make that better. Bigfoot Pharmaceuticals is really interesting. So we have all this technology out there to help people with type 1 diabetes, and we have all these device companies who are slowly trudging forward to try to make a difference with technology. And so a number of parents, starting about 6 or 7 years ago, got together, and if you look at #WeAreNotWaiting, you can see what they're talking about. But they basically developed artificial pancreas systems for their children that didn't wait for the pharmaceutical or the device industry to do it for them. And so a number of those parents got together and formed a company called Bigfoot. And what they are doing is they're taking the basics. They got a pump that actually was no longer being marketed, and they're using it, and they're trying to make really simple artificial pancreas systems for the common man. And they're going to release those so that when you have these really uber fancy Medtronic systems, which are great for a really high-techy kind of person, they're not going to be great for just regular people. So they're working on trials. They're in their initial trials with their system to see if we can do something simpler. And one of the problems with these big device companies is device company A doesn't want to play with device company B. So even though the Dexcom sensor may be better than the Medtronic sensor, people don't want to play together, and they are breaking all those rules. So the guy who used to be the head of JDRF is the president of the company, and it's really fascinating. So I hope Bigfoot succeeds, because it will mean we can have simple devices. And I spend a lot of time in my East LA patients with type 1s who are poor, they have lower levels of literacy, they have lower levels of numeracy, and their ability to use technology is very much reduced. I have a grant where I'm making teaching tools for lower literacy patients in English and Spanish, because if you've ever looked at a pump manual to teach people how to use an insulin pump, it's written at an 11th grade plus level. I mean, you can't have somebody who's got type 1 diabetes who, A, doesn't read English, and B, isn't a very high literacy level anyway, deal with insulin pumps. So a lot of my work is to try to bring technology to people who wouldn't otherwise have access, but who would benefit. So that's Bigfoot. That's a much longer answer.
Please comment more on peripheral neuropathy, or I can think of numbness and tingling.
Well, there's about 1,000 kinds of neuropathy. So there's numbness and tingling, there's gastroparesis, there's bladder dysfunction, there's gut dysfunction, there's the mononeuropathies, any kind of neuropathy you can think of can be caused by diabetes, but there's no specific treatment. The one caution I have is that every single patient of mine with diabetes who goes to see a neurologist with any numbness or tingling is told it's diabetic neuropathy. And diabetic neuropathy is a disease of exclusion. So if it's only on one side, it's more likely to be your back than it is to be, diabetic neuropathy. If it's one wrist, that's carpal tunnel. So, people always blame diabetes. And I think if you have a bad back and you have sciatic pain and your sugars are higher, that pain is probably going to be worse. But the etiology is still not diabetes. So I would urge people that any neuropathy is worked up to be, what is the cause of this, not just to blame diabetes for everything. I get crazy sometimes. I write notes, give this to your neurologist, give this to your doctor that says, this is not diabetes. Do not blame my disease. You can blame all sorts of things on my disease, but not this symptom. It's one-sided, it's sciatic, it's not diabetes. So neuropathy, I just think, is just a horrible complication because I don't have good answers for it. You can try some gabapentin, you can do whatever it is you can, but some of these people get such bad neuropathy that almost nothing touches it. So prevention is the key. All of the tight control, keep glucose levels in a good range. That's the key, is prevention. Wait, somebody in the very, one of you had a question. Right there.
Do you ever see peripheral neuropathy before hyperglycemia and diabetes is diagnosed?
Yeah, so the question is, do I ever see peripheral neuropathy before diabetes is diagnosed? And yes, I see it in people who have seemingly almost undetectable postprandial hyperglycemia. And I don't know that that's the same thing as diabetic neuropathy from hyperglycemia, because I've had a number of those patients, and I put them on continuous sensors, and I make their blood sugars like uber normal, and it doesn't reverse. I mean, there's nothing you can do about it. And I don't know that that's due to hyperglycemia. Again, we're not very good at differentiating amongst different types of neuropathy, but I've certainly seen neuropathy in prediabetes. My husband, on my premarital physical, because I checked his blood, had a blood sugar of 180, and I thought he had diabetes, but it turns out he had prediabetes, and he's a long, lean guy. And all I could think of was him getting peripheral neuropathy from his prediabetes. I mean, that phenomena is etched in my brain because I can't, their glucose lowering doesn't prevent it from getting worse. So I think it's a different thing. And I don't, we're just at the beginning of understanding it.
On metformin in the pre-diabetic, and should we screen hemoglobin A1Cs? Is there a cut point?
So pre-diabetes and metformin is something that's increasingly, it's increasingly recommended. So I used metformin in anybody whose A1C is above 5.7 as pre-diabetes. Now, this is not indicated in the label, and so I am a part of a group. We were discussing this. I do a lot of advocacy. So I'm petitioning the FDA to change the metformin label to let us use it legally as treatment for prediabetes. So the FDA, and we're just a little band of people from the Endocrine Society and the ADA, and we're like, please, FDA, let us do this. And they're like, no, you have to do millions of dollars worth of research and blah, blah, blah to submit an IND. And so then the FDA, only half joking, said, this is your problem. You should lower the diagnosis of diabetes down to 5.7, and then metformin will be indicated because everybody will pretty much have diabetes. And we're like, well, that's really great. But they're really tough about, they require such a level of evidence, and no pharmaceutical company is going to do multi-million-dollar trials on a drug that's $4 a month. So the ADA in the standards of care recommends it. The problem is if you give somebody one prescription for metformin, that then in their chart makes them look like they have diabetes. And so when I treated my pre-diabetic husband and he got a prescription, he was on Actos actually at that point, and some doctor put it in his chart that he was on it. It made it hard for him not only to get health insurance, which was easy because they got it through me, but disability insurance, life insurance, long-term care insurance, just because one place in his chart someone said he took Actos. So just remember that a prescription for a diabetes drug, by definition, makes your patient diabetic. And for a lot of patients who have on Medicare or Medicaid, to justify getting an A1C requires a diagnosis of diabetes. So it's hard you have to consider what you're doing. One way to get around it is to write a paper prescription that doesn't happen to go in the chart that goes to Canada, because the Canadian drug companies, it's cheap. I'm actually not joking. I don't like to get it, in the people's charts, but Canada is great for metformin.
About B12 and metformin, intramuscularly, or do you give it orally?
I just give it orally. The best way to give it, obviously, is to avoid the gut altogether and give an injection once a month. But it's pretty easy to replete yourself if you take a vitamin B12 tablet. I used to check vitamin B12 levels in everybody, and about 20% of patients on metformin will actually have a slow decline in their vitamin B12 levels. And if you just give them sublingual vitamin B12, they end up coming back and staying fine. So you can give them the pill or inject it, but they have to take B12. I mean, it's just vitamin B12 deficiency obviously is going to negate the dementia benefits of metformin. Oh,
Are any of these medications indicated in type 1 diabetes?
The question is, are any of these medications indicated in type 1 diabetes? And the answer is yes and no. So it turns out that not only does metformin is good for people with metabolic syndrome, it also is good for PCOS. And there have been studies looking at metformin in people with type 1 diabetes, and basically it should have the same benefits as in any population. It doesn't lower your A1C much, but you do reduce your insulin dose a bit, and you may reduce your weight a bit. So in East LA, I have all these patients with type 1 diabetes and the metabolic syndrome. So we call them double diabetes, because genetically they have type 2 and immunologically they have type 1. So my patients who are getting older with type 2, who have central fat, they're dyslipidemic, their HDL is low, they're hypertensive, I consider those phenotypically, they're type 1 and type 2. And so I put them on metformin because I actually think metformin probably has more than glucose effect, and it also does help their blood sugars a bit, but it's not indicated. And then SGLT2 inhibitors and GLP-1 receptor agonists have been used. GLP-1 receptor agonists don't work that well. SGLT2 inhibitors actually are beneficial, but they can increase the risk for DKA. So you really have to know what you're doing in order to use them. But I basically use type 2 drugs in my type 1 patients who are looking more and more like type 2s. You know, we used to think of type 1s as skinny people, but it turns out that even in kids, that's just the same obesity rates as the population. So a third of type 1s are obese, a third are overweight, and a third are lean. And so a lot of times I can't tell if an older person has type 1 or type 2 just by looking at them. So it's a certain confusion. And it also turns out that 50% of all patients with newly diagnosed type 1 are older than the age of 20. So our understanding of type 1 diabetes, you can get it at any age. My oldest new onset type 1 was 92. So you can get type 1 at any age. We're currently seeing an epidemic of type 1 diabetes in people in their late 50s, early 60s. So just remember, if it looks like type 2, it still could be type 1. So you have to think. But yes, I use off-label all sorts of type 2 drugs in my patients with type 1 who I think are patients who are at risk for the metabolic complications of diabetes. And you know, it's a much longer discussion. I do a lot of coronary calcium scanning because in the DCCT, they do coronary calcium scores to see who needs to be on a statin and who doesn't. And I don't want to put every type 1 on a statin if they don't have the disease. So I do coronary calcium scores in my type 1s as they get older to see if they need to be risk modified for cardiovascular risk. The woman in the back standing up.
Metformin do you use and when do you stop it?
Metformin, the dose that's being studied for healthy aging is 1,500 milligrams. So if I can get someone up to 1,000 or 1,500, I use it, but then they stay on it forever, as long as their renal function's good. People should, if you're on metformin, you should never stop it. It's like it should be in the water. It just should be there. So don't stop metformin. It should just stay because it's got so many long-term potential benefits in terms of health. So it's not just glucose lowering. Remember, we're thinking of these drugs as helping reduce that residual risk for cardiovascular disease that exists, not just glucose lowering. So metformin just should always be there, whether someone's on insulin, whatever you do with your type 2s, keep them on the metformin.